Hello, my name's Dr. James Thomas, and I'm the Medical Director for West Yorkshire NHS Integrated Care Board. And I'm also a GP working in modality partnership in Bradford District and Craven. And I'm really pleased to be here to be able to discuss with you how clinical leadership helps support and influence clinical commissioning across West Yorkshire, and how important it really is when we look to commissioning health services for our citizens that we do this in partnership across health and care services and organisations, which includes our voluntary sector and obviously the patient. So hopefully at the end of this short talk, you'll have a better understanding of what NHS commissioning is and the role of the doctor and the clinician in the new structure. How and why partnership working with organisations across health and care, including our voluntary sector, is so crucial. And also I'm going to just focus on general practice and how general practice is part of that as a provider of care in the arrangements across our health and care partnership. So what is NHS commissioning? Well, essentially, it is about ensuring that the NHS uses the pot of resources and funding in the right way to deliver the best health outcomes for our people that we serve across West Yorkshire. But really it's about working with the organisations involved in delivering that health and care in West Yorkshire to ensure those services are available, accessible to people, and are of the right quality of care to deliver the best outcomes for our people of West Yorkshire. So what do I mean by best outcomes? We want to ensure people are healthy, so that people will have the best start in life, so that you can live and age well and die in a place of your choosing. And we will work to ensure that you are not disadvantaged because of where you happen to live, your background, or what you do. And if you have a long-term condition, a condition like asthma or heart failure or hypertension, you'll be offered personalised support to self-care. And if you have multiple health conditions, you'll be supported by a team of people like the GP, community care staff, teams, social services, all working together and will involve the person and their family and their carers. So working across the NHS and social care and our community organisations like our voluntary sector to work on really what matters to that patient there. But sometimes people need hospital care as well. So this will often mean your local hospital in your area, that hospital will work closely with the community teams to make sure we give the best possible care. But sometimes these hospitals will require more specialised services and will be supported by centres of excellence for services such like cancer, vascular work, stroke, and some of our complex mental health problems and conditions. So all of this is planned and paid for once between the NHS, the local council, and then working through our organisations together. But the key thing is about ensuring the patient is at the centre of everything we do as a partnership of organisations. And as a partnership of organisations, we build that trust and that common purpose to enable this. Now, you may sit there listening to this, and many other people do listen to this and think, well, doesn't this happen already, or expect that this is what automatically happens and it's second nature? But this has not always been the case for many decades, as many of our organisations have been set up to compete to deliver that high quality care. And often that has resulted in many of our bigger organisations being the main providers, which may be the right thing, but so often we see that our care is delivered by smaller organisations like the voluntary sector, and it's delivered more so in our communities and in our homes. However, in West Yorkshire, we've been working hard since 2016 to really develop kind of better working ways and partnership working to enable our system to integrate its services and develop those partnerships across health and care and to enable a kind of an environment in which we can develop and mature as organisations in partnership. So since 2016, this has been done with no legislation, and we have been the West Yorkshire Health and Care Partnership. However, in July of this year, national legislation in England was passed through the Houses of Parliament, and the arrangements were changed by law to abolish what were the clinical commissioning groups, otherwise known as CCGs, which West Yorkshire had 5, with Bradford District and Craven, which I happened to be chair of at that point, Leeds, Calderdale, Wakefield, and North Kirklees. And whilst they've been abolished as organisations, they've come together still in their places to form the Integrated Care Board of the NHS West Yorkshire. That covers those 5 places, who will be accountable for the delivery of NHS care across West Yorkshire and foster that integrated care approach that we've been developing really since 2016, as explained before there. So as a system and through our partnership working, we are expected to deliver on national targets on people's experience of care through their experience in A&E, through cancer treatments, mental health, or operating lists. We're expected to achieve the long-term plan for the NHS for the 2.4 million people that live in West Yorkshire, with the money and resources that are available to us. However, our plan is much broader than just the long-term plan of the NHS in scope. It's about addressing the priorities of local government and the third sector partners, as well as the NHS. And as an integrated care board, our mission is really to ensure that we improve those outcomes in our population health and care, and also reduce those health inequalities we have seen. It's also about managing the unwanted variation in care across our places. But it's also about utilising the collective resources wisely, and by doing that, securing the wider benefits of investing in both health and care. And we do this by ensuring we work in partnership. And there are plenty of examples of how this has taken place. And a lot of it, and most of it, takes place in our communities. And I suppose the most recent thing that you've probably heard of and seen and been part of potentially is the COVID vaccination services. And that's a great example of how different organisations have come together to deliver an agile and accessible service. And that service was where most of the delivery of the COVID vaccine was probably through our groups of GP practices working together in groups called primary care networks, or otherwise known as PCNs. And they were working with their communities to ensure the delivery of the vaccine. And whether that was out of the traditional GP surgery, or actually more working with their communities, often with smaller voluntary sector organisations, to work with specific communities or groups of people to deliver the vaccine, whether that was in churches, in mosques, in shopping centres. But out of the traditional GP surgery, to ensure that our services were accessible to our communities. Because so often we hear the phrase, people are hard to reach, when in fact it's really our services that are hard to access. And this only causes greater health inequalities. And I think the COVID vaccination is a great example of how GPs have worked with the voluntary sector, with their help of the communities, and how that voluntary sector has often helped access some of those communities where traditionally they were seen as hard to reach. But actually, when we put our services in their communities, working with the voluntary sector, with trusted leaders of those communities, we've seen the kind of much improved uptake in services like the vaccine. So we're kind of building on this work to look at how we do other services in a similar way, like our health checks for people with severe mental illnesses, severe mental problems, with health checks with people with learning disabilities, so that the services really become more accessible. And to me, this is true partnership working, GPs working with voluntary sector groups and our community leaders, champions, patient champions, our community pharmacists, to deliver and care, kind of healthcare in our communities, to really reduce those health inequalities and to reduce that kind of variation of uptake of our services we've seen for so many years. And this is how clinical leadership, along with our leadership of our organisations in our communities, can really help facilitate and deliver these services in partnership. So I mentioned at the start, I'm a GP and I'm a clinical leader within our West Yorkshire system. But I'm passionate that clinical and care professional leadership is core to the arrangements of commissioning and delivering healthcare in West Yorkshire. The vaccination example I've given and just described demonstrates not only the partnership working with the voluntary sectors and our communities, but it also demonstrates how clinical leadership has enabled the right decisions to be made at the right time. But the vaccine work is probably only one obvious example where this has taken place. We see this across our acute trusts, all working together to ensure they deliver services in the right place at the right time. And examples of that would be with some of our vascular work, some of our stroke services. Our mental health trusts have worked together to ensure that we have beds and services for our most complex patients with mental health disorders. I'm sure you'll hear from other organisations, I think, like Bevan Healthcare, who work closely with mental health and addictive behaviour organisations to provide care to people who are homeless or have just arrived as a refugee in our area. All these examples demonstrate how working in partnership across health and care and in our communities with the voluntary sector and with the patient at the centre of what we're doing enables the delivery of accessible care that's right for the individual. So when I say clinical and care professional leadership, I mean that in its broad form. It's not just about doctors like me or GPs. It's not just about doctors and nurses. It's about including many of our other allied health professionals, like physios, who we now see across hospitals, our communities, and in our GP surgeries. It's also about our social workers, who are vital to the delivery of care to a lot of our patients. Other people like pharmacists who work across many of our health organisations in our communities, and are probably one of the highest touch points in primary care in our communities for healthcare, for advice along with GPs. So it's key that when we look to develop and deliver services, we involve and use our clinical and care professional leadership to help influence and transform our services. If we are also recognising the impact of the voluntary services and the impact of care, we also need to ensure that they are involved too. Leadership is not about one person, it's not about one profession, but it's key that we recognise that as we work closer with other organisations, whether that's with GPs working with GPs or GPs working with acute trusts or mental health trusts or GPs working with community pharmacists, this is all about a multi-professional approach that enables those leaders at all levels to influence. Because we know that whilst I sit here and I speak to you as the medical director of NHS West Yorkshire, I know that most decisions and most of the work takes place in the consultation room with the clinician and the patient, and that is where decisions should take place, and most of our decisions do take place. But we also need to recognise that sometimes if those decisions can't take place there in that consultation room or in that patient's house or home, then it should take place closer to them, so in our communities there, or across the place, like across Bradford or across Leeds, North Kirklees, Calderdale, Wakefield. But it only really takes place at West Yorkshire. The decision takes place at West Yorkshire when it cannot take place in those places or in the patient's home or in the surgeries or hospital setting. Or it makes sense really actually to do once at a system level there. And that is why clinical and care professional leadership is vital at all levels, and especially in our communities where that is where most of these things happen, and that's where most of the decisions are made. So it's really key that we have leadership there. So I know you will be at a stage of wanting to understand the medical role and the details of how to consult, how to examine, how to diagnose, and then when you've diagnosed something, what are the treatment options? And that's absolutely right. I can recall that myself. That was my focus there, and that's really important. But I would urge you to look at the broader element of care, and at what other care is available, and also what really matters to the patient that's sitting in front of you when you're talking to them. So whilst I sit in my consultation room seeing patients who have multiple conditions like heart failure, diabetes, hypertension, COPD, and depression, and some people will have all of those. And as a clinician, as a doctor, I will want to do the best for them, and really want to make sure that each of those conditions I'm treating them appropriately. And that's important. But I also must ask the question, kind of what really matters to them. Is giving them 4 or 5 more medications the right thing to do? Because it might be the right thing to do individually for all those conditions that I've talked about. But if it brings with them a load of side effects, well, it means their whole day is about when to take pills. Am I really adding value and quality to their life? And is it really what matters to them? Or would it be better to refer to maybe someone like our social prescriber in our practice, who might look to help explore with the patient what those real issues that the patient is concerned about? And sometimes it's often those broader issues. It's the issues like debt. It's the issues like housing. It's issues like social isolation that really they are suffering with and from and need that help. And that's what's really worrying them and impacting on the patient there. So things, and it's interesting. So things like heating, if they're not able to heat their house, actually we often see greater admissions to hospital, seeing GP for their asthma care. So actually sorting out their heating actually may mean that we don't have to manage their asthma as much as we are doing at the moment because of their heating crisis for them. So it's really important that as we're having these discussions, there's shared decision making in that consultation, and it's really important as a GP that I absolutely do not have all the answers, but I do need to consider those wider determinants of health, and then be able to kind of look to where I can signpost the patient to others who do have that knowledge, do have that expertise, or that ability to connect people to those other issues and wider issues. And those are people in practice as a GP, like our social prescribers, but it's not always a social prescriber. There may be others there, and some of our voluntary sector organisations will be key to that. So I love my job, combining clinical work where I strive to work in partnership and leadership with others in my practice there and with my patient, and that's key with my work. But it's also a focus with my leadership role in West Yorkshire, where so often those principles and behaviours of what I do in my surgery are so common with my role that I have at West Yorkshire. So my role at West Yorkshire and what I do in surgery is about me being ambitious, so that the decisions made are motivated by a shared purpose, whether that's with across the system with organisations and clinical leaders I talked with, or actually is it with my individual patient I'm seeing in the consultation room. It's also about working in partnership, so we collaborate where it makes sense, and to see diversity as a strength, and that's key both again at a system level, but also in my consultation room as well. And it's also about me using evidence and data to be able to critically think whether I'm doing the right thing. Is there something else I should be doing? And what's best? What's the best data out there, and evidence? And again, that's something I'll be doing as a system leader, but actually in my consultation room, I'll be thinking that as well there. So I'm coming to the end now of my talk with you. Thank you all for listening. I hope from this short talk that you've heard really what NHS commissioning is and the role of the doctor and the clinician within the commissioning structures and the partnership across West Yorkshire and the West Yorkshire Integrated Care System. I hope you've understood a little bit more about how and why partnership working with organisations across health and care, including our voluntary sector, is so crucial to delivering care, especially if we're looking at trying to ensure we improve outcomes for people and we are reducing those health inequalities and the unwanted, we're improving on reducing the unwanted variation we see across our places and our communities there. And I hope through my experiences as a GP and some of the examples I've given you that specifically looking at general practice, you can understand how general practice is part of that as a provider of care in the arrangements of delivering health and care to the citizens of West Yorkshire. So I look forward to answering any further questions when we meet up in the future. And once again, thank you very much for listening, and see you soon. Thank you.